During this presentation, we will be discussing the renal system. My name is Sophie and I will be going over nursing interventions for a client with kidney stones and renal system complications.
Hi, my name is Sinead and I'll be talking to you about the complications of the renal system.
Hi, my name's Casey and I'll be discussing the interprofessional team.
Hi, my name's Georgia and I'll be discussing the pathophysiology of the renal system as well as the pathophysiology of renal calculi.
Swinburne Hospital Emergency Department, 12 o'clock, the 9th of the 10th, 2019. Graham, a 74-year-old male, brought in by his wife Cheryl. He has 8 out of 10 sharp pain in the back around bilateral anterior flank and lower back that radiates through to his stomach. Obs are as follows: heart rate 97 and regular, temp 37.8, BP 167 on 90, resps 28, O2 is 93% at room air, and a blood sugar level of 18.6. Graham's current medication is ibuprofen, paracetamol, atorvastatin, atenolol, metformin, hydrochlorothiazide, and Novorapid. His lifestyle consists of takeaway most nights, drinks 2 to 5 beers per day. He's retired but is not financially stable. He lives in a rental property with his wife. He is obese and smokes approximately 20 cigarettes per day. Graham has a medical history of hyperlipidemia, which was diagnosed in 1997, hypertension, diagnosed in 2005, atrial fibrillation, diagnosed in 2005, history of depression, diagnosed in 2006. He's a type 2 diabetic, diagnosed in 2011, which has been poorly managed since, and 1 year ago he passed kidney stones naturally. Graham's family history consisted of his mother being diagnosed with hypertension in her 40s. His mum also suffered from kidney stones recurrently in her later years. Both parents were overweight. Mother died of a heart attack at the age of 63, and father developed type 2 diabetes in his late 50s.
The renal system. The renal system consists of the kidneys, ureters, bladder, and urethra. The main function of the renal system is to maintain homeostasis within the body. It can perform this by various functions. The kidneys are a pair of reddish-brown organs, approximately weighing 120 to 170 grams for an adult. They're 12 centimeters long, 6 centimeters in width, and 2.5 centimeters in thickness. They're located behind and outside the peritoneal cavity at the 12th thoracic vertebrae to the 3rd lumbar vertebrae of the posterior abdominal wall. They're pretty much behind all our intestines. Each kidney has 3 layers. The first layer of the outer layer is called the cortex. The second layer, the inner structure, is called the medulla, and these have fan-shaped small structures called pyramids. Then finally, the innermost layer is called the renal pelvis. So how do they work? Well, blood enters the kidneys via the renal artery, and then they branch off and become smaller into capillaries. These microscopic capillaries are nephrons, and each kidney, they contain approximately 1 million of these nephrons. The nephrons are essentially the powerhouse for the kidneys. These nephrons contain the glomerulus, Bowman's capsule, proximal tubule, loop of Henle, distal tubule, and collecting ducts. Their role is to filter the blood as it passes through and to make urine. Making urine involves a 3-step process, which involves glomerular filtration, tubular reabsorption, and tubular secretion. Glomerular filtration occurs at the glomerulus, and only small particles are processed from the blood. These larger molecules, like proteins and red blood cells, are then excreted via the vasa recta, or the peritubular capillaries, as they cannot pass through. Once blood passes through the glomerulus, it becomes filtrate. We make about 180 litres a day of filtrate. So the filtrate then begins to pass along the convoluted tubules to the loop of Henle, into the distal convoluted tubules, and finally it ends up in the collecting ducts. As the filtrate flows through these areas, tubular secretion and reabsorption can then take place. The kidneys have many functions. It's not just fluid in, fluid out. They also excrete all our body's metabolic waste products. They regulate our electrolytes, regulate our acid-base balance through the reabsorption of bicarbonate and secretion of acid, which means they pretty much just maintain our pH levels. They control our water and sodium levels, regulate our water excretion, they maintain our blood pressure through a very extensive and complex system. They regulate our red blood cells, and they turn inactive vitamin D into its active form, and they also secrete prostaglandins. So once we make filtrate, what happens to it? Well, it branches off from the kidneys into a tube called the ureter. So just like the kidneys that are a pair, so are these. They connect kidney to bladder. Our bladder is a hollow sac that stores our urine. And how much urine do we make? Well, we approximately make 1,000 to 1,500 mils of urine each day from this whole process. So when our bladder is full, the urine then passes through the urethra. Renal calculi is the presence of stones within our renal system, and it varies in location. Calcium oxalate is the most common of renal calculi. Risk factors that increase the possibility of renal calculi formation includes obesity, cardiovascular disease, including hypertension, gout, chronic kidney disease, diabetes, and dyslipidemia. It affects more men than it does women, and it spans across all ages. A sedentary lifestyle, high protein diet, low fluid volume intake increases the risk. Pathophysiology of renal calculi. In individuals with crystal urine and high levels of concentration, tubular cells become injured, and crystals can be more readily available to attach to these damaged cells. Once the crystal combines with the renal tubular injured cells, they grow and bind together to form a stone. In healthy individuals without crystal urine and high levels of calcium oxalate, crystals are digested by our macrophages and lysosomes once they attach to the renal tubular epithelium, and they are easily passed via our urine.
Complications of the renal system. A generally healthy person from time to time may experience an acute kidney injury such as a UTI. This is generally pretty quickly and easily diagnosed and treated, and the person then returns to their normal self quite quickly. In more serious cases of acute kidney injuries, the patient can become very unwell if left diagnosed or untreated. This can either be a short-term issue that once diagnosed is rapidly treated. However, it can become a chronic problem causing serious damage or complete failure to the renal system. Acute kidney injuries can be caused by low blood pressure, dehydration, severe diarrhea, or bleeding, whereas chronic kidney injuries can be caused by uncontrolled diabetes, recurrent kidney infections, high blood pressure, and toxic medications. Acute injury is something that is short-term and easily reversible once treated, whereas chronic is unreversible injury to the kidney over a very long period of time. Polynephritis is also known as kidney infection. Kidney infections are more common in females than males, however still occurs in males. In females, the urethra is shorter, therefore there is a shorter distance for the bacteria to travel into the kidneys. Infection of the kidneys can either start in the bladder and track up to the kidneys, or can start somewhere else in the body and track to the kidneys via the blood. An infection in the kidneys is very painful for a patient, and they would present with either back pain, groin pain, fever, vomiting, changes in urine habit, including the colour of it, the frequency that they urinate, the odour, or the feeling, so something like burning. A kidney infection is usually diagnosed through a urinalysis and blood tests. Treatment is usually antibiotics. Depending on how severe, it can be oral or IV. Renal calculi, commonly known as kidney stones. Lots of people get them. They are hard crystal-like formations that usually form in the kidneys itself or in the ureters. No one knows why they are formed. However, research suggests that diet, medication, blood calcium, hydration status of a person, and uric acid levels in the blood all play a part. A person presenting with renal calculi would be passing small or no amounts of urine, have blood in their urine, have a fever, or have the feeling that they want to urinate all the time. Diagnosis is usually generally through CT, ultrasound or X-ray, depending on the location of the stone. Treatment is generally invasive, that being surgery. However, lithotripsy is commonly used for smaller stones that, if in the right location and can be broken small enough the patient will pass naturally. Lithotripsy uses shockwave therapy that passes from a table through to the person where the area of concern is. Depending on how big the stone is, therapy can range from 20 to 40 minutes, and analgesia IM can be administered during this time. The patient is awake for this the whole time and is generally discharged within an hour of completion of the therapy. Blood in the urine can be present for up to 4 weeks, and this is quite normal. However, any major concerns should be raised with the urologist. Although there may be slight pain during the procedure itself, it is a less invasive procedure than surgery, and the patient generally passes the stone within the 4 weeks, naturally. Sepsis. Sepsis is a life-threatening condition where an infection in the body spreads into the bloodstream, poisoning the body. Each hospital generally has a sepsis pathway protocol to document and escalate a deteriorating patient. A patient exhibiting signs of sepsis needs to be closely monitored. They can deteriorate very quickly. A patient that is turning or is septic will have an increased respiratory rate, a drop in blood pressure, an increased heart rate, and a temperature spike. Changes in blood flow around the body affects the function of the kidney. A prolonged event of insufficient blood to the kidney can cause permanent kidney damage or failure.
As Graham has presented to hospital with an elevated respiratory rate of 28 rests per minute and on further investigation oxygen saturations of only 93%, oxygen therapy may be required. Graham should be sitting on over 95% for his age, and taking into consideration he is a long-term smoker. Prior to commencing oxygen therapy, it is important for Graham's nurses to position him in a semi-fowler position and educate him on taking deep breaths to see if this improves his oxygen saturations. If oxygen therapy is still required after these interventions, then 2 to 4 litres via nasal prongs should be administered with continuous oxygen monitoring and 30-minute respiratory rate observations at a minimum. It is also highly important for the nurse to remember to communicate with the client and his family, as this can assist with determining what the client's normal observation ranges are. Another nursing intervention that would be important for Graham is undergoing a urinalysis. A urinalysis needs to be completed for every new patient admitted to the ward. This test is especially important to carry out for Graham due to his presenting symptoms of pain and blood whilst passing urine. The urinalysis can measure the amount of blood present along with the levels of certain minerals that contribute to the formation of kidney stones. The urinalysis can also detect signs of infection. A urinalysis is done at time of admission, can also assist to determine when the client is improving due to their stay, as multiple urinalyses will be taken during their admission. In order to perform a urinalysis, Graham will need to be given a specimen jar and provide an adequate amount of urine for the nurses to get an accurate urinalysis. The urine will then be sent to pathology for further testing that may not be able to take place on the ward. Although as a nurse, we cannot order a CT scan or ultrasound, we can bring it to the doctor's attention why we think a client may require one and would be responsible for any preparation the client may need for the scans. In some wards, the nurse may also be responsible for taking the client to and from the scan and ensuring paperwork such as doctor's orders are present and completed correctly. In Graham's scenario, the symptoms are likely a result of kidney stones, and therefore to determine size and confirm location, an ultrasound or a CT scan may be required. The doctors can use these results later, determining the best treatment methods such as medications and surgery. Client education is highly important in order for clients to receive the best care possible. Ensuring Graham has a good understanding on his current medical conditions and how his medications works plays a role in ensuring treatment post-admission. Including Graham's wife in the client education is also important as they live together and can assist with implementing new routines, diets, medications, and assisting with an effective and efficient recovery. educate on kidney stones and how to try and avoid reoccurrence, such as increasing fluid intake, increasing intake of calcium-rich foods, and reducing consumption of animal protein such as meats and eggs should be provided.
Antispasmodic drugs are under the drug class alpha blockers. An example of this is tamsuline. It assists in stone clearance by lowering blood pressure, which keeps the muscles relaxed, allowing them to improve urine flow from the kidneys and widens the track for the stone or stones to pass through. Side effects can include headaches, skin rash, weakness, nausea, vomiting, tachycardia, and most commonly dizziness. This drug cannot be used in patients with a history of hypertension or patients who have severe renal failure, that being a creatinine clearance of less than 10 mL per minute. In relation to Graham may have had lithotripsy in previous cases of renal calculi and been placed on this medication. If not, depending on the doctor's diagnosis of this presentation, he may have lithotripsy now or surgery, so that would depend if he goes on an antispasmodic medication or not.
NSAIDs inhibit COX-1 and COX-2, blocking prostaglandin production. They have an antipyretic, analgesic, anti-inflammatory effect. An example is ibuprofen. Side effects include acute kidney injury, gastrointestinal upset and ulcers, dizziness, headaches, hypertension. They are contraindicated with multiple drugs, including beta blockers, thiazide diuretics, kidney disease, and alcohol consumption. In relation to Graham and his comorbidities, over-the-counter ibuprofen is clinically inappropriate due to its drug-on-drug interactions and NSAID's ability to alter the renal function. In Graham's case, if renal function is compromised, side effects and renal toxicity is a potential. Education should be provided to Graham to cease use of over-the-counter ibuprofen, and other alternatives for pain should be explored.
Analgesia is a group of medications that are used to reduce acute, chronic, or breakthrough pain. Examples of this group of medication include paracetamol and endone, which are classified as analgesia and antipyretics. These medications work by interrupting the nerve signals between the location of the pain and the brain. Graham's presenting symptoms would indicate that he would benefit from analgesia due to 8 out of 10 pain.
For patients suffering from kidney stones, thiazide diuretics are the preferred choice. This is due to their ability to decrease the amount of calcium in the urine by increasing calcium absorption in the kidneys. Although thiazide diuretics can decrease the potential of new stones forming, it is often used in conjunction with potassium citrate, as when the two drugs are given together, they potentiate each other's effects. They do this by stimulating the kidney tubule cells to reclaim calcium back into the blood. Thiazide diuretics are also very effective for treating hypertension, which our patient also suffers from. To care for our patient on a holistic level, we need to assess both the current and underlying issues. By collaborating an interprofessional team mode of care, we can better identify and treat his range of health concerns. This mode of care has been demonstrated to improve outcomes of patients, especially those with chronic illness. The design of the interprofessional team is to provide thorough assessment, treatment, and support for self-management and follow-up to meet individual client needs. Developing a detailed patient history, medical diagnosis, plan of care, and identifying potential return home risks. Each patient's team is developed uniquely and tailored to their individual needs. In the next slide, we will discuss the team requested for our patient's care. These will be the nurse, occupational therapist, medical team, social worker, diabetic educator, psychologist, and dietitian. The nurse will undertake a nursing assessment and then develop a care plan based on the individual's needs, taking into account both short and long-term goals. They are responsible for continuing care and patient teachings in relation to the team's needs. They must liaise closely with all members of the team as nursing staff are the main care providers. We make comprehensive notes for documentation, care for our patient at the bedside, and consider discharge planning by assisting our patient to acquire new skills. The social worker acts as an advocate by liaising with existing community groups and resources, and assists the individual to deal with social, domestic, financial, and emotional implications. They engage in discharge planning and work closely along the occupational therapist. The patient will require social work due to his social, financial, and emotional state, as he has identified he doesn't have financial independence, he is isolated at home, and he is neglecting his home care. The occupational therapist's role is to assist the patient to obtain independence or modified independence in activities of daily living. They will assess any home modifications required, also teaching adaptive methods. The occupational therapist will assist in making the home more accessible, catering for our patient's changing needs, assisting our patient with new techniques to cope at home. Psychologist looks at the cause, prevention, and treatment of social, emotional, mental, and behavioral disorders. Our patient has identified that he suffers from depression but is not managed appropriately. Our team will assess and provide mental health care while in the hospital and continue to offer care in the home. The diabetic educator will provide evidence-based best practice diabetes education to ensure optimal health and well-being for all people affected by diabetes. Our patient has noted that he does not have control of his diabetes and he is having to administer insulin with every meal. He has poor intake choices, measured obesity, and current medication issues, meaning he requires assistance with his diabetic control. The role of the dietitian is to assess the nutritional needs of the patient by either restricting or modifying intake, collaborating closely with the care team and the individual. Our patient will require the dietitian as he is obese and not preparing appropriate meals, leading to increased weight, uncontrolled diabetes, and all of these factors are continuing to contribute to his recurring kidney stones. The medical team is responsible for the medical management and oversees treatment by the interprofessional team. They will also make the appropriate referrals and organise any follow-up care. Potential risk factors for our patient when looking at a multidisciplinary team structure are that of non-compliance. Our patient may refuse any or all of these services, both within the hospital setting or once returned home into the community. This will have a significant impact on the patient's kidney stones, taking longer to resolve in the future. The National Safety and Quality Health Service standards that apply to the interprofessional team are clinical governance, partnering with consumers, preventing and controlling hospital-acquired infections, medication safety, comprehensive care, and communication for safety.